Hello, everyone. And thank you for joining us today as we are going to discuss the importance of supporting caregivers and families in our communities and our healthcare system. This webinar is being offered today by the Ottawa Valley Ontario Health Team and its members. The OVOHT is made up of more than 50 local health professionals, healthcare providers, organizations, and community members who are working together to improve our health system and connect patients to the services they need. Ontario Health Teams are a coordinated way of organizing and delivering care that is more connected to patients, families, and caregivers in their local communities. Through Ontario Health Teams, or OHTs, groups of healthcare providers, including hospitals, doctors, and home and community care providers, we are working together to deliver a full and coordinated system of care for patients, no matter where they provide care, and even if they're not in the same organization or physical location. The session today is being provided among a series of webinars before we launch our one-day Aging in Place Forum on May 15th. This full-day event will bring together healthcare professionals, service providers, policymakers, decision makers, and community members to work together to create a shared 10-year vision for aging in place across the Ottawa Valley Ontario Health Team. We are delighted to share our keynote speaker and facilitator is Zaina Kayat, Health Futurist. Please reach out to the Ottawa Valley OHT for more information to register for this full-day free event. I am pleased to be your moderator for this session today. My name is Sarah Utrunke, and I am a Director of Patient Services for Ontario Health at Home and member of the OHT Steering Committee. I have accountability for community and hospital programs in Western Champlain, as well as our intake and short stay teams regionally. I am a registered nurse, and prior to working in the home and community care sector, worked primarily in the hospital sector. I am based in Renfrew County, and am thrilled to be part of the change that is happening to modernize and transform the health system to support patients and families to age in place within their preferred home setting. At this time, I will complete a land acknowledgement. The Ottawa Valley Ontario Health Team and its partners are located on the traditional, unceded, and unsurrendered territory of the Anishinaabe Algonquin people. The Algonquin people have inhabited and cared for these lands since time immemorial. We take this time to express our gratitude and respect to them and to the land for all that it has provided and will continue to provide. While we recognize that territorial acknowledgements are only one step in cultivating greater respect for and inclusion of Indigenous peoples, we commit to accompanying these words with actions. We are dedicated to building a future and community that is better for all. We pledge to continue exploring and making meaningful contributions to the Truth and Reconciliation Commission of Canada's calls to action. So on today's topic, what is aging in place? Aging in place means having the health and social supports and services needed to live safely and independently in your home or community for as long as you wish and are able. Many older adults and their families prioritize staying in their homes and communities, and aging in place can help maintain independence, social connections, and a sense of familiarity. Ontario offers various programs and services to support aging in place, such as in-home supports, transportation, and access to healthcare, to name a few. Our speakers today are Catherine Boudens and Kunal Parikh. Catherine Boudens has been with Ontario Health at Home for 15 years. Catherine is a registered nurse and has filled many roles within our organization while working at the front line with patients, performing duties in care coordination. She is also a wound care specialist and trained as a geriatric assessor. A true and formal leader on our team, Kathy is also an avid dog lover who enjoys spending time visiting seniors at Marion Hill with her facility therapy dog, Daisy Duke. Our second presenter today is Kunal Parikh. Kunal is a passionate advocate for social justice pertinent to aging, caregiving, and disabilities, a digital health strategist, and a dedicated educator. Originally a practicing physician in India, he pivoted to health tech to pursue the potential of technology to improve patient safety. He holds a postgraduate degree in digital health from Algonquin College and a master's in aging and health from Queen's University, where he earned the Award of Excellence. Kunal has worked at the intersection of healthcare, technology, and education with a focus on addressing care inequities for older adults. Currently, Kunal works as a senior systems analyst at the Ottawa Hospital and is an adjunct professor in the digital health program at Algonquin College. We will start our time together today with a presentation starting with Catherine and then over to our colleague Kunal. We invite you to add questions to the chat function or raise your hand, which we will monitor and respond to at the end of the presentation. I would like to note that today's session will be recorded. And with that, I will hand the presentation over to Catherine.
Thank you, Sarah. I'm going to talk about Mary, and it's a patient's story. Next slide. Mary is an 84-year-old female living at home with her elderly spouse on a rural road in the outskirts of Pembroke. Mary had no services in place and was referred for an assessment for services after a weekend visit to her local emergency room after she had a fall. The emergency department did a workup, ruled out a UTI, and she was noted to have multiple medications in her file, but unable to identify the reasons for the medications with the nurses. She was also noted to have a wound on her coccyx. Following the initial history follow-up, an initial history was obtained by a phone call by our ED care coordinator, and this is what we learned. Next slide, please. So our key findings that we found out was that Mary has two supportive sons who live in the area and are working full-time. They would like to support their parents to live at home with support. They report that mom is having a change in her cognition, does not seem to manage her personal care like she once did, appears disheveled with soiled clothing at times, which is not like the once tidy mom they grew up with. She's had 2 recent falls and no mobility aids or bathroom equipment in place. They worry about their father as he's not capable of managing as he once was. So our key considerations and perspectives, the patient's goals and wishes. We want to look at the patient's perspective, preferred location to age and place, meeting needs and changing health profile, support both available to her, and she is willing to accept. We want to look at the caregiver's perspective, look at his goals and wishes, resources available to provide support, ensure caring and attention to prevent burnout. System perspective, supports available to meet goals and wishes, prevent unnecessary hospitalization and or premature admission to facility and risk mitigation. Next. So the next steps, the patient's going to have a home visit that was scheduled with the community care coordinator. We go in the home, we do a complete assessment, and then we establish the care plan with the patient and the spouse. We obtain consent from them at the home visit and make a follow-up telephone call to the sons to review the services and providers that we're going to put in place to support their parents, and then provide contact to the care coordinator for future needs. And then the caseload is going to be assigned for future reassessment and ongoing monitoring to a care coordinator in the community. Next step. Next slide. So our care planning options for Mary include the PSS to assist with personal care, referral to a high intensity support at home program, and nursing for wound care, physiotherapy for mobility and transfer falls risk assessment, PT to recommend if OT would assist with equipment needs in the home, referral to a specialized geriatric services, and community support such as Meals on Wheels, Marion Hale Homemaking, and the paramedic program. We're going to discuss respite for the spouse and family. So in-home respite, caregiver respite distress program, referral to the short stay respite and long-term care, resources for Marion Hale overnight respite at the McCluskey Center. Also make a referral to the adult day program which will allow Mary to go out for the day from 9 till 3, which also gives the spouse time away from caring, and then to look at retirement home options for a short stay. Long-term care planning, options explored for retirement home living, long-term care counseling regarding process and wait list, start to open up conversation regarding advanced care planning if needed. And then finally, we're going to establish the care plan to support Mary and her family. So Mary and her family are the center of the care. We're going to put in daily personal support to assist with bathing and dressing, and nursing for the wound care. We're going to do in-home respite with a caregiver distress program, and then add PT to address for falls and equipment. We've initiated a long-term care file. We made a referral to Marion Hale for homemaking, and also a referral to specialized geriatrics for a more thorough assessment of her cognition and potentially a diagnosis. What's the benefits of the care planning for Mary? Patient experience an improved quality of life, meeting her goal to remain at home safely. Spouse and son express having a peace of mind with supports and future planning in place. With care and planning, we've avoided further emergency room visits. And that is the end of my presentation. I will now turn the session over to Kunal.
Thank you so much. That is a really good snapshot of a story. Basically, whenever we're trying to discuss caregiver support or aging in place, it always helps to humanize it, and a case study or an example like that is the best way to do that. I will be leading the rest of the session, and the topic, as I was trying to determine what is the title that I want to give to this session, we want to talk about caregiver support because obviously caregivers are extremely important to the whole idea of aging in place. But then we have these silos of caregiver support in our system right now. So what I want to do is take you on a journey with me where we rethink caregiver support for aging in place. There's so much focus and importance that is being given to the movements of age-friendly cities and aging in place, but it cannot be discussed insulated from caregiver support. Both of those have to exist together. In fact, caregiver support, effective caregiver support, has the potential to make this vision of aging in place a reality. So the plan, as I have thought about, is we want to talk about 4 different chapters. Each chapter will talk about a very specific and niche thing. The first, we talk about understanding the caregiving landscape or setting the stage about the caregiving crisis in Canada right now. It's a very pulled back and a very systemic perspective. The next chapter is the caregiver's journey. This is where we go a lot deeper into the individual perspective of the caregiver and how the caregiving journey evolves. And then we go on to the next chapter, which is anatomy of the ideal caregiver intervention. This is 100% a nod to my medical roots. I used to love anatomy, which is why this chapter is called Anatomy of the Ideal Caregiver Intervention. And the last, I do recognize that we talk about interventions a lot in the context of urban areas, but rural communities have unique challenges. So we want to talk about innovative pathways for rural communities as well. How does that sound? Does it sound like a good plan to you? Awesome. This is your time. You are spending 1 hour of your life, of your work day here. So I want to provide as much value as I can. So if you have any questions, if you have any comments or feedback, I want to hear them all, literally hear them all. Please use the chat box or unmute yourself. I'm open to anything. Okay, so chapter 1, understanding the caregiving landscape or setting the stage. Now, 1 in 5 Canadians are 65 plus years in age right now. By 2030, 1 in 4 Canadians will be over 65 years of age. Now, alongside that, 1 in 4 Canadians right now are caregivers already, but by 2030, 1 in 2 Canadians will be a caregiver. Now, this is not to say that, oh my God, we should be scared. What do we do with this sudden increase in the aging population? No, no, no. The crisis is not because we have an increased number of older adults. The crisis is because our system is unprepared to deal with the needs of older adults and caregivers. 1 in 5 caregivers live in a rural area, which obviously presents unique challenges in and of itself. Some additional statistics that I would like to highlight is 3 in 5 caregivers, that is 60% caregivers, are over 50 years of age. I was doing a caregiver group last week, and one person said, I'm caring for my aging parents. My mom is 85 years old, which means I'm no spring chicken myself, which makes sense. The caregivers are also getting older in age. Women are more likely to provide care than men, 42% to be precise. And most commonly, caregivers provide care to aging parents or spouses. 5.1 hours of care on average per day. And at the same time, 1 in 5 caregivers, 20% caregivers, spend more than $1,000 per month out of pocket. Now, if you reframe this in terms of, labor laws, for example, it's almost as if caregivers are taking on an extra job where they're spending about 5 hours every day and they're not getting paid for it. Instead, they're paying the job for doing that. So anyone who's passionate about economies should squirm at this point. This is not okay. This is a crisis. And despite all of this, only 1 in 4 older caregivers actually access services and supports. These are the caregivers that can actually use respite care. They can actually use training. They can use support groups. Yet, maybe because it's an awareness issue, maybe because they don't see themselves in that service, the utilization and adoption of these services and supports is quite low. So, as Kathy kind of alluded to this in her part, we want to move from the conventional ideas of person-centered care. Typically or traditionally, when we say person-centered care, it focuses on the older adult. It focuses on them making decisions that appear to be in a silo and they do not affect anyone. It makes the assumption of radical autonomy. Think about it. Ever since we were children, we are all taught to be self-sufficient and independent. But radical autonomy is a myth and a trap because our lives are deeply intertwined and we all lean on one another in various degrees and in various ways. So this whole traditional concept of person-centered care, which focuses on the idea of independence, seems outdated to me. We need to move away from that towards more of dyadic care. And this dyad comprises of the older adult and all of their caregivers. It focuses on the shared experiences, goals, and needs. We're talking about if there is a decision to age in place, what impact does it have on the caregiver? What supports do the caregiver need to make that happen as well? So it does not focus on independence. Rather, I'm encouraging all of us to move away from that towards interdependence because we are in legitimate relationships in our lives, and recognizing this interdependence is the only way forward. Now, when we conceptualize interventions, a best practice is to kind of try to dig into the worlds of the individuals who will be using those interventions. So let's take, sorry, are you guys able to hear me okay? I just see okay, perfect. I'll keep checking. I'd love to dig into the worlds of the caregiver and the older adults. I'd love to examine what challenges they face and what are their aspirations. Let's begin with the older adult. The main challenge, one of the key challenges that they face, especially in rural communities, is transportation and mobility. A lot of times, when older adults are advised by their doctors or occupational therapists, it's time to hang up the keys. The main hesitation comes from the fear of what am I going to do if I can't drive? How am I going to get to places? Which kind of feeds into social isolation as well. If I'm not able to get to my weekly euchre club, if I need to depend on my caregiver, who is probably also really busy in their own life, if I can't get there, I'm going to be a lot more lonelier. I'm going to miss out on those that banter with my friends. Also, there's economic constraints. Getting old is an extreme sport. It is really expensive. All the medication you might need, the likelihood of chronic conditions increases over a certain age threshold. So and the pension is not what it used to be. So there's economic constraints as well. Now, what are their aspirations? As Kathy also mentioned, aging in place seems to be older adults seem to have a fervent desire to age in place, and that makes sense. They have lived in a certain home all of their adult lives, and they would like to continue living there. It makes sense. They'd like to maintain connection with their community. There's a lot of pride that comes from being able to contribute in civic ways to the community, and older adults would love to maintain that connection. And equitable health services. This is a loaded one. We have in Canada, our healthcare system was designed to treat acute care. There's a very simple formula with acute care. You diagnose, you treat, and you rehabilitate. End of story. And we're kind of transplanting that same framework onto chronic care, which does not work. Chronic care requires a lot more preventative ideas. It requires ongoing control. And that means the health services that are available to older adults might not make a lot of sense. And at the same time, they need services that do cater to their unique needs. What about the caregiver? Some challenges that they face are pretty similar to what the older adults face. Limited access to services. There's so many stringent criteria with how and when can I get access to respite? How many hours is the respite care worker allowed to come and help me out? There's complex systems navigation. I am within the system. I live and breathe in the aging and caregiving space. But when my partner and I were providing care to his uncle at the end of his life, it was just very challenging because there's so many systems to navigate and there's no clear answer. There's a lot of context that determines which system you can get access to. So this is a real big issue. And then financial strain. Of course, there's the direct cost of caregiving, like medication and equipment, but there's also the indirect costs, such as what if I need to take days off of work? Uh, I'm losing my income. What if I need to pass on a promotion because the promotion comes with added responsibilities and I don't know if I can let go of my care duties. All of that also contributes to financial strain. And what are their aspirations? They also really want better support systems. This is going to be kind of the central theme of the whole presentation. We need to design better support systems. Caregivers want to be recognized as collaborators and partners in care delivery. Let's break it down. So, collaboration means sharing of expertise. So, as a doctor, I know what treatment options would make sense for a certain individual. But as a caregiver, only I possess the expertise and knowledge of what my loved one likes, what kind of soda do they like, what time do they like to eat dinner, what time do they like to wake up, how do they want their life organized in a certain way. So caregivers need the recognition as collaborators. And then partnership. Partnership is shared decision making. There's obviously a bit of paternalism when it comes to the healthcare system, where decisions are imposed or downloaded onto people and their caregivers, but caregivers need to be equal partners in the care delivery as well. And then to balance safety and autonomy, this is the age-old debate. Should I focus on keeping mom safe, or should I just honor her wishes and let her walk without using her cane? It's a very difficult spot to be in. Now, again, we're going to peel this layer even more. These are the challenges and aspirations, but how do they come to fruition? As we said, aging in place is a norm. Everyone wants to grow old in the home that they live in. And that is because um, when you're living in the same place for more than a certain period of time, it provides a part of your identity. It anchors your personhood. And of course, you're attached to it. Now, at the same time, long-term care homes have received a bad reputation of being of having medicalized and sterile environments. So it doesn't feel like home. So even though they're called long-term care homes, they don't always feel like home. We're doing a lot better there. Don't jump at me, but that's a historical, a conventional perception. So when there's a decision to move to a long-term care home, in society, it's looked upon as, oh, is the caregiver giving up? It's not really said out loud, but that's basically the thought process that goes on behind it. And why does that happen? Because there's a traditional expectation of familial responsibility. Listen, I'm Indian, and um, I hear this from my parents at least once a week. I gave birth to you, so you obviously need to, A, B, and C. Um, and there's just this traditional expectation that care, adult children care for their parents. Now, this expectation also leads to decentralized support systems. The expectation that families and communities will provide care has led to fragmented policy approaches at federal and provincial levels. Now, this decentralization results in uneven access to services depending on the geographic location, and this is exacerbated in rural communities. Now, for Indigenous caregivers or those from marginalized communities, caregiving roles are shaped by cultural values that emphasize collective responsibility. However, mainstream healthcare systems often fail to recognize or accommodate these cultural differences, and this leads to feelings of invisibility and exclusion. I'm going to pause here and see if there's any questions or any comments or um, anything that really stands out to you. All right, we're going to keep going. Chapter 2, the caregiver's journey. So far, what we've talked about is at a very high level, systemic perspective of the caregiving crisis. Now we're going to talk about the individual caregiver's journey. What does it mean to be a caregiver? Let me paint this portrait of caregiving. We often think of caregiving as primarily physical or medical support, like helping someone bathe or dress or move around. And yes, that is certainly a vital part of caregiving, but it is also just what is most visible or the tip of the iceberg. This role is a lot more expansive than most of us realize. Caregiving is also emotional support, being there to listen or to comfort or to provide companionship. It is mental support to provide advice, to help make sense of difficult situations or clutching their hand in the doctor's waiting room. It is social support, planning an outing, or being a friendly face in a crowded room. It is also being an advocate. So sitting in that medical appointment with them, asking questions and ensuring that their voice is heard. Sometimes it also includes financial and legal matters and coordinating services and navigating the complexities of their health. As you can tell, this is an all-encompassing role. But yes, this is everything that caregiving encompasses. How does the caregiving journey begin? At what point do you say, okay, yes, I am a caregiver? This is where I would like to introduce the idea of the care span. We talk about lifespan a lot. You're born, and then you have your childhood years, adolescence, older adulthood, and then older adulthood. In the same fashion, we're going to talk about the care span. There's 6 different stages. The first stage being the stage of possibility. This is where the caregiver is saying, this is not my role yet. The person does not really identify as a caregiver, even if they're taking care of someone. They may be unaware of the extent of the help they need or deny the emotional or logistical impact of caregiving. They might just brush it off as, oh, I'm just being a good son or a dutiful spouse, you know? The next stage is the stage of realization. This is where the person starts to realize that they are becoming or they will become a caregiver. They may feel uncertain, overwhelmed, or ambivalent about the responsibility, but they're beginning to consider what it means for themselves and for the care recipient. Next comes a stage of preparation. This is where they step in. The caregiver starts to gather information, look for resources, contact Kathy to help with care delivery options, perhaps adjust their lifestyle, and then begin preparing. They begin to prepare for the emotional and practical demands of caregiving as well. For example, I know that no one's available to just sit with mom in the morning, so I'm probably going to ask my employer if I can begin at 10 a.m. instead of 9 a.m. Simple changes. The next stage is the stage of engagement. This is where the caregivers are in the thick of it. The individual is actively providing care and making real-time decisions. They're dealing with physical, emotional, financial, and logistical challenges, and they may seek out support or strategies for coping and self-care as well. So this is a phase where the most of the burn happens. Next stage is the stage of adaptation. This is where caregivers have found their rhythm. The caregiver has adapted to the role, they've found routines and developed coping mechanisms, and they're maintaining self-care routines, support networks, and they're being resilient while continuing their caregiving duties. And the last stage is the stage of transition. This is where the caregiving role ends, most likely due to the death of the care recipient. There's a common misconception that the stage of transition might happen if the care recipient is moved to a long-term care facility. That's completely incorrect, in my opinion, because when someone moves to a residential facility, only the nature of caregiving duties change, not it does not mean that it is the end of caregiving duties. In the stage of transition, the caregiver often needs time to process. They need to deal with their grief, but at the same time, something magical happens as well. They start to reclaim their personal identity and find new purpose. Now, I'm going to actually pause again, and I'm going to ask for your opinion on at which stage do you think um, should we approach caregivers and offer them resources? You can feel free to unmute yourself, or you can type it in the chat. I am persistent.
Oh, we have an answer in the chat from Jade, and she's saying step 1. Kunal, Brigitte, go ahead.
Thank you, Sarah. Thank you, Kunal. I think at every stage, we should be engaging the supporting caregivers throughout the care plan and in every engagement with the patient, providing that we have consent.
You're so right. There's it, and Jade is right as well. It does begin at step 1. Why is this conversation important? Because when we provide support to caregivers, it is imperative for us to meet the caregiver at the stage that they are. That is the only way an intervention can be effective and the intervention can actually work. And that is why genetic interventions do not work. There's a comment, the process is not linear. Absolutely, you're so right. This is, as you can tell, adapted from the trans-theoretical model, and the forward transition from the first stage towards the last is not linear. It depends on the self-efficacy of the individual. As you can imagine, the self-efficacy is low at the beginning when there's a new diagnosis, for example. The caregiver adapts to it, they learn strategies, and then they get used to the role. They may reach engagement, adaptation, and then maybe something new happens. Maybe there's, as you said, a fall that happens, and it kind of resets things because it's overwhelming. When there's an extrinsic factor like that, which kind of disrupts what you've learned so far, your self-efficacy erodes and you go back a few stages. So you're absolutely right. The process is not linear, but this is a lot of it depends on how well the caregiver is able to adapt, which is what I'll talk in the anatomy, where we need to do a lot better at helping caregivers adapt to the ongoing challenges of caregiving. Barney, absolutely. It depends on the condition, chronic disease exacerbations. And with chronic diseases, as long as there's a baseline level of baseline that's maintained, things are going well. But when there's an acute exacerbation, that's when you go back a few steps. There's also another comment: moving to long-term care has changed since COVID. Many fears. 100%. This is that's a whole another webinar of its own. I'm not going to go a lot deeper into that, but you're totally right. I'm loving the conversation, honestly, because only through unexpected, difficult conversations can we grow and can real change happen. So please keep this coming. I appreciate the conversation. Okay, Chapter 3, we're going to talk about the anatomy of the ideal caregiver intervention. Now, if we want to design well-rounded caregiver interventions, we need to be able to foster self-management behaviors of caregivers. In the context of an individual, self-management means I feel confident to manage my own condition. In the case of caregivers, self-management means something a lot more. It means they're confident and capable of managing not only their own care, the self-care component, but also the care for someone else. So there's 4 components that we need to focus on. The first one being health promotion. A lot of times, many caregivers might not even realize that they are caregivers. So if we do health promotion in an effective way, the caregiver should be able to say, yes, I am a caregiver. The second being psychoeducation. At all points of time, caregivers need to develop new skills and new ways of dealing with the ongoing challenges. And if we're able to provide training and education to caregivers, albeit informal or as personalized as we can make it, the caregiver would be able to say, I can do this with a broken heart. The third component is support systems. No caregiver can do this alone. And all of us can yell from mountaintops, you are doing so well and you're doing the best you can, and you're amazing. However, if another caregiver with similar lived experiences would say that to the caregiver, it means something entirely else, which is why at the end of support systems, with support systems, the caregiver should be able to realize, I'm not in this alone. And the fourth component, caregiver wellness. You cannot pour from an empty cup, and that's exactly what applies to caregivers as well. If we do this component well, caregivers are able to realize, I deserve care too. And not just for face value, but they truly believe that they deserve care. Let's talk about each component in more detail. So with health promotion, the idea is to understand that the label of caregiver or the role of a caregiver is gradually constructed. There is a lot of hesitation to adopt this title, and a lot of this is because subliminally, we associate caregiving with healthcare providers. It's a noble characteristic which is associated with expertise and compassion. We've made this role really heroic, so us common parlance cannot see ourselves as such, which is why we need to use softer language, such as, do you care for someone? If we avoid using the label of caregiver, we might be able to reach more people, and gradually we can construct this role of the caregiver. Let's provide connections to community resources like Meals on Wheels, rideshare, because these are things anyone can use. This is what will reduce the caregivers' attention, and it will provide them more bandwidth to adapt and cope with the other caregiving duties. And we have to increase caregiver visibility in media and policy. As the picture here is Bruce Willis and his caregiver. It's always stirring to read about the caregiver experiences of his wife. And it makes me think it's really beneficial because number one, it helps increase representation. And number two, if people like Bruce Willis and his caregivers who have so many resources at their disposal, if even they deal with such challenges, it's okay for us to have these challenges. It's okay, which is why caregiver visibility is extremely important. I am going to put in a plug for myself here. Recently, I did a TED Talk on the topic, Did you know you are a caregiver? And in this, I talk about a lot of barriers to self-identification of caregivers. One of them, or the most common one, is the gradual onset of caregiving. Think about it. When you become a parent, the birth of a child marks that clear transition into the new role, right? With a caregiver, it begins one small act of care at a time. Oh, I'm just driving mom to her appointment. Oh, I'm just picking up groceries. I'm just like picking up the medication. And then a few years later, I find myself responsible for the entire medication schedule. So caregiving begins small and it compounds. And I don't know how to pinpoint the exact moment when I became a caregiver. Second, there's societal expectations of familiar relationships, because of which caregiving is concealed under the disguise of duty. Oh, you're just, doing what you're supposed to. It's your filial obligation, and that's a load of, you know what. And then the third one, there's apprehension of what caregiving will bring. We fear that self-identifying as a caregiver will lock us into that identity and we will lose out on the role of the son or a daughter that we truly cherish. Because it also calls for significant responsibility and emotional labor and potential sacrifices. And maybe I'm in denial and maybe I don't want to adopt this new title. And all of this is really valid, and we need to acknowledge these barriers before we initiate our health promotion initiatives. The next component or the next domain is personalized psychoeducation. Now, the goal of this is to help caregivers make informed choices pertinent to the care delivery. One of the most common mistakes that education providers and training providers make is, oh, we're going to tell caregivers these are the problems you will face and this is exactly how you solve them. The idea is not to provide like a master list of problem inventory and like solutions, but we need to teach caregivers care skills that are transferable between situations. Some of the key skills that we should be focusing on: understanding the disease. So what are the common changes to expect? What are some unusual behaviors to look out for, like wandering? Medication management. Next, we need to talk about nurturing the relationship. So what are some meaningful activities you can do with your loved one to reminisce or enhance your collective well-being? Communication skills, redirection, reorientation work really well. Next is performing ADLs, bathing, dressing, mobility, toileting, but then it needs to go beyond that surface level messaging. We need to teach caregivers gentle persuasion techniques, because unless the recipient gets in the bathroom, the bath is probably not going to happen. Next, prioritizing caring for themselves. This includes obviously active self-care activities, but also balancing work and caregiving. That's a skill. Navigating negative emotions like guilt or anger, frustration, anxiety. These are not abnormal feelings. These are very valid emotions to have. But how do you manage those in the moment? That's a skill. And then advanced care planning. This talks about living wills, POA, documents, advanced directives, things of that nature. There is a grid that I worked on. I know this is a really, really tiny graphic, and I'm not gonna go into this in detail right now. But if you would like to receive this infographic with the generic curriculum of caregiver training, please put your email in the chat. I'm more than happy to send this your way. A lot of what we're talking about, the skills acquisition or skills development, should also take into account Lorigan Holman's excellent framework on self-management. Sorry. We need to be talking about problem solving. Yes, you have a problem. How do you analyze how big of a problem it is? What are the solutions? How do you select an option? Or like, how do you select the best thing to do in that moment? And that is decision making. How do you enhance provider partnerships? How do you make sure that your voice is heard? How to ask the right questions to the providers? Utilizing resources. There's so many beautiful and amazing resources available right now, but there's not a lot of awareness. How do you find resources and then utilize them? And then the last one is taking action. All of this might fall flat if we don't talk about executing them, taking action, thinking about accountability, right? So all 5 of these will be are the hallmarks of self-management that we should be focusing on. All right, the third domain, which is support systems. This includes a lot of peer support groups, mentorship, online discussion forums. Of course, if this comes from another caregiver, it just means something entirely else, and it has so much more impact. Again, I'm going to go back to my caregiving journey with Brian, my partner's uncle. He was at the end of his life. He had cancer. We knew he was going to pass away in 3 to 4 months, and nothing brought us more comfort than the support group that we went to, where we just talked about, we're doing the best we can, and another caregiver kept saying, "You've got this." They had no empirical proof that we've got this, but they kept saying it, and it made us feel really, really good. Sorry. Um, Next, it also helps validate lived experiences as valuable. There might be well-meaning people or friends of caregivers who might say, well, why don't you just take the day off and come hang out with us, and it will take your mind off of caregiving things. But that does not happen with other caregivers. They know exactly what you're living through, and they understand that to you might not be able to take that time off. And something very helpful is practical tips and strategies from others with similar experiences. Again, from that support group, someone taught us it is okay to bribe your care recipient with whatever they want. In Brian's case, it was Coke, the drink, to be clear. And it helps. All of this really enhances this micro community where we're not so alone, we're not so isolated. It helps. It helps with bonding, and it's really important for caregivers who might otherwise not have good social health. Okay, that's very theoretical. Those are the benefits. How do we actually make it happen? So it absolutely takes a village. Cultural norms of reciprocity, so neighbors helping neighbors, for example, are assets that can be nurtured and intentionally supported. Now, I'm working with this project with Carleton Community Health Center in Ottawa, and we're doing asset-based community mapping. It's essentially just a map to identify who's already helping. It includes friends, nurses, friends, um, retired individuals, neighbors, and people like that, and also assets that may otherwise not be as well known. For example, there's this amazing art class that happens at the museum on Friday mornings that we didn't know about, and we found out because someone else told it to us. Next, faith-based communities like churches and temples, they often provide a lot more than just spiritual care. They often host meal drop-offs, prayer circles, and organize caregiver relief efforts. Grassroots mobilization for meal trains, respite support, and informal transportation services. I cannot tell you how helpful it is to just even have a ride to go to the clinic. And lastly, again from my experience, community institutions like libraries, PHCs, pharmacies, local pharmacies as well, are excellent at being this hub of vital information for caregivers. Let's make good use of community resources that can act as support systems. And then the last domain is caregiver wellness. I want to emphasize this as much as I can. It is way more than just respite. Now, it is imperative that the caregiver intervention focus on the caregiver's own wellness. And self-care allows this opportunity to come to terms with my own emotions, regulate them, be more mindful, be more rested, recharged, and as a result, be more present when I'm providing care. Caregiving is exhausting, and taking time for yourself is not selfish, it is actually necessary. All of this will also increase or improve my self-appraisal. I am, in fact, doing enough. You can objectively see that what you're doing is making a difference and you can do no more. With self-care, caregiving becomes a lot more sustainable, and that's just a simple law of economics again. So I promise I'm getting to a conclusion. What does self-care actually look like? In our capitalist economy, we've obviously found a way to monetize the simple joy of self-care, but it does not always have to mean an expensive bubble bath or a spa. self-care can be broken down into 4 components as well. Physical self-care is you have a nourishing meal or you go for a walk. Get an 8-hour sleep. Mental and emotional self-care. So you participate in your hobbies, you paint, you write in a journal. So what if your painting looks like it was done by a first grader? You don't have to be good at it. Next, social and relationship self-care. Call a friend, lean on them, talk to them, and you can ask for help as well. And then there's spiritual health, self-care. Meditate, spend time in nature. There's a comment, it can be very difficult when an aged person is caring for an aged person and has 24-hour duty, not just a 5.1 hour. Absolutely. It's so true. And I truly empathize with people who have, like 24/7 caregivers. And this is where this whole framework would be helpful, because if we're able to provide respite and the skills to set boundaries, it might be helpful. But I get what you're saying. It's not always feasible. It is not always materialized.
Something that really resonated with me, Kunal, as you were speaking, just to start off, if anyone has anything to add, when you were talking about the grassroots supports and the value of our communities. I do think it's a real strength here in Renfrew County, and we even have like pockets within regions of those types of supportive groups. We saw it through COVID and how the communities helped one another. But what got me thinking is, why does that need to stop with COVID? That was something that really resonated with me personally. So, a lot of thoughts for me on a personal and professional levels. Huge thanks to Catherine for your grounding story, and to you, Kunal, for your really wonderful dynamic lecture. I think it brought so much to us as Ottawa Valley OHT members and folks that are in the industry. And I think the conversation can continue on at our Aging in Place Forum on May 15th. So I would encourage anybody that is not sure whether they would attend, please come and join us for our forum. This has been a wonderful way to start to set the stage on the thinking going on there.